One, we are live, so you can start.
Good evening. A warm welcome from Cipla, and I welcome all of you to this international symposium on navigating the COPD management with nebulized therapeutics. Now, nebulized drugs are available since many years, not only from the short-acting bronchodilators. Now, nebulized drugs are also available in the form of LABA and LAMA, and even in India, we are fortunate to have the fixed dose combinations available in nebulized formulation. Now, inhalation is the fastest, easiest, and safest way of giving medicines. But we must understand which patient profiles, where to go, what to do, because we get patients everywhere, right? From in the emergency room, in the OPDs, at home. So to delve this topic in deeper, we are joined by an international eminent speaker, Dr. Mario Cazzola. Dr. Mario Cazzola is going to speak on delving into the nebulized drug delivery from hospital to home. After his talk, we will have a panel discussion on optimizing the use of nebulized therapeutic armamentarium in the patients of COPD. And this panel discussion will be moderated by Dr. Deepak Talwar. Dr. Cazzola will also join as a panelist. Along with Dr. Cazzola, we are joined by Dr. Mahavir Modi and Visweswaran B. So I'll share my slides and introduce all of them to you. Okay. Can you see my slides? So Dr. Mario Cazzola doesn't need any introduction. He's a very eminent and senior pulmonologist joining from Rome. Sir is an MD, FERC, Chair of Respiratory Medicines, Department of Experimental Medicine, University of Rome, Torretta, Italy. We are fortunate that he has accepted his invitation despite being on summer holidays. Thank you, sir, for joining us. We are also joined by Dr. Deepak Talwar. If I start introducing Dr. Talwar, I think it's like introducing to a son. He doesn't need any introduction. He's an MD, DTCD, DNB, DM. He has multiple fellowship to his credit. Currently, he's the Director and Chair, Pulmonary Sleep Critical Care Medicines, Metro Center of Respiratory Diseases, Noida. Thank you for joining, sir. And we also have two senior pulmonologists joining from India. From Pune, we have Dr. Mahavir Modi. He's an MD. He has fellow in cardiac imaging. He's also a fellow in interventional pulmonology. He's a senior consultant pulmonologist from Ruby Hall, Pune. Dr. Modi, welcome to this program. And from Hyderabad, we have Dr. Visweswaran. Dr. Visweswaran is an MD, DNB, and DM. He also has a fellow in interventional pulmonology, fellow in sleep medicine. He's a consultant in interventional pulmonology, Yashoda Hospital, Hyderabad. Now, for those who are joining today's program, while registering, you can put your questions in the box, and we can take up the questions after Dr. Cazzola's lecture. Dr. Cazzola, over to you.
Okay, thank you.
We can see your slides. Just make it full screen.
So I can start.
Yeah.
First of all, good evening. And thank you very much for this kind invitation. Although I'm in holidays, as I said, I am really proud to be part of this group of experts on this very important topic. Well, they have asked me to give you some information on nebulized drug delivery. That means to be focused on COPD. And if I must be focused on COPD, I must start repeating what you know very well. That is, the treatment of COPD is focused on the use of long-acting bronchodilators and, in some cases, with the addition of an inhaled corticosteroid. When we start the treatment, according to what the GOLD strategy suggests, we must look at the blood eosinophil count, and if there are at least 300 cells per milliliter, we can add inhaled corticosteroids. But the initial treatment cannot be enough in our patients. In these cases, we can be thinking to change the treatment or to improve the treatment. If we are focused on dyspnea, for sure the best approach is to move to dual bronchodilation, combination of LABA, but also consider switching another device. If we are mainly focused on exacerbations, well, in this case, triple therapy with LABA/LAMA plus an inadequate corticosteroid is extremely important, but the patients must have at least 100 eosinophil per microliter in the blood. This is what the gold strategies suggest, but I must highlight that the significant differences between what is recommended and what we do, mainly if we are general practitioners, can be observed. Here in this Italian study, we were able to observe that there was an overtreatment in patients in gold group A and B, and under-treatment in patients in group D. But what is important is that 45% of patients in group A and B were treated with a long-acting bronchodilator therapy in combination with inhaled corticosteroid. But this is not only an Italian problem, to be honest. If you look at the first-line treatment, you can see that in US, systemic steroid bust is the most common first-line treatment. Whereas in the Netherlands and Estonia, LAMA's monotherapy is the first-line treatment. In the UK, SABA monotherapy, in Spain, SAMA, and in South Korea, Xanthine. But the problem is that even when we look at the type of the second line and third line treatment, always in patients with COPD, of course, we can observe a wide variability within and between the database. And this is a big problem because compared with the real-world clinical practice, there are many patients, a significant great proportion of patients that can be treated with an escalation of treatment according to what is suggested by GOLD 19 and GOLD 23. This stresses a gap between real-world practice and updated treatment recommendation. I think that there is a great confusion between general practitioners because of the continuous changes made by the GOLD recommendation. Don't forget the major shift represented by the exclusion of severity of airflow limitation as maybe the major factor in guiding therapies. And this is a real problem for general practitioners in adhering and prescribing therapies that are consistent with the algorithm proposed by GOLD strategy. But I must also highlight that the inconsistency in COPD treatment can also be due to the substantial workload that GPs often experience. And this can limit the time and resources that they have for staying updated with the evolving guidelines. But also, I think that is extremely important, the fact that the GOLD strategies endorsement of various diagnostic tools that can yield different levels of diagnostic accuracy. I am thinking, for example, at MRC and CAT. There are substantial differences between the two, but if you look at the GOLD, they are at the same level. Well, this can complicate the adherence to the recommendations. And another concept that is difficult to be accepted by general practitioners is the concept of the frequent exacerbators. That is a notion that is not universally accepted by them, and this further complicated the implementation of the guidelines. Furthermore, there is another problem that we must consider. For example, a large international COPD primary care database from Europe has shown that 34, that means 1/3 of mild COPD patients had at least one exacerbation per year, and 12% had at least two exacerbations per year. This is a problem because this suggests that we should use inhaled corticosteroid to prevent exacerbations. And we know that there are subgroup of patients that can better benefit from inhaled corticosteroid. Therefore, there is a need to identify such patients in order to optimize the risk-benefit ratio and improve treatment outcomes. Of course, we are focused on exacerbation, on symptoms, and on eosinophil counts. But inhaled corticosteroid alone are not enough to treat COPD. There is a clear evidence. Look at this data produced by a Cochrane systemic review that ICS-LABA combination treatment is related to a fewer exacerbations, and what is important, probably to fewer severe exacerbations than ICS alone. We are complete in agreement with this concept from a long time. And we believe that if this is the case, probably a combination with budesonide and formoterol could be the best approach to our patients. In effect, we have documented that the addition of budesonide influences the fast onset of action of formoterol, although it doesn't induce systemic effect in patients with stable COPD. Furthermore, we were able to document in 3 small but significant studies that a combination with a single inhaler of budesonide plus formoterol was efficient in reducing acute exacerbation with COPD. So it can be considered an alternative to traditional therapy in the treatment of acute exacerbation of COPD. Of course, in patients suffering from COPD, we are afraid about the impact that a beta-2 agonist can have on arterial blood gases. Well, we documented that combined administration of formoterol and budesonide reduces the potential for acute effects of formoterol on blood gas tensions. In any case, the important trial published by Peter Calverley and colleagues that explored the effect of a combination of budesonide and formoterol for 1 year in patients suffering from COPD documented that this treatment prolonged the time to first exacerbation and was able to maintain higher FEV1 when compared with the placebo. Patients is treated with ICS-LABA had fewer pre-bronchodilator, have a higher bronchodilator peak expiratory flow, and fewer exacerbations, and showed an important improvement in St. George respiratory questionnaire. That means a substantial improvement in quality of life when compared with the placebo. And in any case, the combination was more effective than either monocomponent for all these variables. I am not surprised that we can find such a type of response when we use an ICS-LABA combination. In fact, as we, with my friend Ronald Dahl, were able to stress many years ago, the LABA-ICS combination has additive effects on the pathophysiology of COPD in terms of airway obstruction, inflammation, structural changes, and mucociliary dysfunction. And this because this type of therapy addresses the multi-component nature of COPD better than LABA or ICS treatment alone. There is also a strong pharmacological rationale to combine LABA and ICS in COPD. We know very well that LABAs cause bronchodilation, but corticosteroids have no significant anti-inflammatory effect when used alone. I am speaking about COPD, not about asthma, of course. Corticosteroids are able to increase the expression of beta-2 adrenergic receptors and may restore the reduced numbers of these receptors. The reduction of this receptor can be due to the effect of TGF-beta. In turn, the LABAs may restore responsiveness to corticosteroids. So it is important to combine LABAs and ICS, although gold strategy today say that we must avoid to start the treatment with the lab ICS. I completely disagree with this suggestion. And I have a support also from data coming from real world. Semi-Swiss published this very interesting study in which is documented that both budesonide formoterol and fluticasone salmeterol were able to reduce the incidence of moderate severe exacerbation in real world activity. But what was important is that budesonide formoterol was more effective than fluticasone salmeterol at reducing the incidence of severe exacerbations. In any case, all these drugs, both LABAs and ICS, must be used by inhalation. In effect, the inhalation for the treatment of COPD and also asthma is the preferred route of administration because of several important reasons. For example, the therapeutic agent cannot reach adequate concentrations in the lungs when given systematically. There is a significant systemic toxicity of the therapeutic agents when given at doses that reach therapeutic concentration in the lung. This is a problem. The drug has a poor oral bioavailability and therefore would need to be injected to exert its effect in the lung, and a rapid onset of action is needed when we use, for example, short-acting bronchodilators, but even fast-acting bronchodilators, such as formoterol. Of course, we have different approaches when we want to deliver a drug by inhalation. We can use metered-dose inhalers, we can use dry powder inhalers, we can use soft mist inhaler or nebulizer. Nebulizers, as you know very well, are devices that have been designed to contain medication that can be dissolved or suspended in a liquid solution, which is transformed into inhalable droplets through the use of compressed air, ultrasonic waves, or vibrating mesh mechanism. In general, any formulation could be used with any nebulizer, but I must highlight that this leads to wide different outputs. Think about aerosol particle size and those to the patients. Nebulizers are often used to deliver pharmaceutical aerosols in patients' population that cannot effectively use an MDI, even with a spacer or a DPI. In many patients that require ventilatory support via invasive mechanical ventilation or non-invasive ventilation, and in those who suffer from severe exacerbation, mainly if they have some alteration of consciousness. In any case, there are patients that might find the nebulizer delivery of a drug medication to be a more effective approach, since an optimal dose is delivered by normal, I mean tidal breathing, regardless of disease state. We know that no specific inhalation technique is required when we use nebulizers, and there is no need for hand strength. Furthermore, many nebulizers come with face masks, meaning that old people and those with the consciousness alteration that are frequent in COPD, I must admit, can use them. Furthermore, I think that the interest in use of nebulizers has increased because of the relatively high cost of HFA formulations. We have several different nebulizers to generate aerosols for inhaled drug delivery. For example, we can use jet nebulizer that deliver compressed gas through a jet. There are various different modifications to the basic jet technology. Think about a jet nebulizer with a corrugated tube, jet nebulizer with a collecting bag, breath-enhanced jet nebulizer, and breath-actuated jet nebulizers. And in my opinion, as we have stressed in this article, in which also Omar Usmani was a co-author with us, I say the evolution of jet nebulizers has culminated in introduction of breath-enhanced models that are designed to facilitate the entry of air during inhalation while simultaneously expelling exhaled air externally. And this can contribute to a more efficient system that facilitates a faster delivery of therapeutic agents compared to standard jet nebulizers. Furthermore, generating aerosol only during inhalation increases inhaled mass and decreases ambient drug loss. This was a very important concept when we used the nebulizer during the COVID periods. We can also use mesh nebulizers that use a perforated membrane or mesh or plate with multiple apertures to produce an aerosol. And we also can use ultrasonic nebulizers that convert electrical energy to high-frequency ultrasonic waves that are transferred to the surface of a liquid and in this manner produce an aerosol. Of course, there are substantial differences between jet, ultrasonic, and mesh nebulizers. And these differences favor ultrasonic and mesh nebulizer if we are focused on treatment time, on output rate, on sound. But there is a problem that ultrasonic and mesh nebulizers have a high cost, whereas jet have a low cost. And this is a very important issue that must be considered. For example, in my country, this is a very important problem because the national system prefers to pay less. And so they tell us to use jet. And I think that also in your country, this is a crucial problem that you must consider. There are several consensus groups that have explored the literature and related to nebulizer, of course, and have give suggestion on how to use them for maintenance treatment in patients with stable COPD. I will be focused just on some of them, of course. For example, I must start with gold, not only because this is a so popular strategy, but also because I must highlight that until 2010, gold states that nebulizers are not recommended for regular treatment because they are more expensive and require appropriate maintenance. But in 2010, gold no longer stated that nebulizers were not recommended for patients with stable COPD, although they remained cautious regarding the use of nebulizers. Since the 2017, however, gold report caveats regarding nebulizer use are no longer presented. Although in 2023 and even, of course, in 2024, gold report, we can still read there is no evidence for the superiority of nebulizer therapy over handheld devices in patients who are able to use these devices properly. But please don't forget that gold notes, however, that patients included in clinical trials are very well trained and monitored for correct inhaler use, and therefore they may not be reflective of routine clinical practice. What is extremely useful to all specialists, and not only specialists, that want to use a nebulizer has been reported in the Indian guidelines for nebulization. These are likely not because I'm speaking with the Indian colleagues, but because I must recognize that this is completely true. This is probably the best document that we have worldwide related to the use of nebulizers. Well, according to these guidelines, nebulization therapy can be used in intensive care unit, commonly for delivering bronchodilators, anti-inflammatory drugs, antimicrobials, and mucolytic agents in mechanically ventilated patients. Although I must highlight that the nebulized bronchodilators in ventilator-supported patients are recommended only in obstructive airway disease. Also, Indian guidelines report what I said before, that is, jet nebulizers, despite several disadvantages and their variable performance, are those who are used more frequently because of the operator's familiarity and ease of their operation, and for being less expensive. Furthermore, these guidelines recommend use of only those drugs for nebulization which are available commercially and are indicated in patients in intensive care unit. Please don't forget that even according to these guidelines, we have several drugs that can be used, but also can have the perspective to be used in mechanically ventilated patients. Not only antimicrobials, but also anticoagulants. Don't forget the importance of heparin. My group and Clive Page group in UK have produced studies on the anti-inflammatory importance of heparin, for example. Bronchodilators, of course, corticosteroids, diuretics, mucolytics, anti-diabetic drugs, although I never would like to treat my patients with insulin because of the risk of bronchoconstriction, prostanoids, sulfact, and so on. According to your Indian guidelines, nebulization therapy can be used in obstructive airway disease in those patients who are unable to use handheld devices because of altered physical or mental status or poor hand-breath coordination. Nebulization therapy can also be used in these patients if they suffer from a severe airway limitation that requires high doses of bronchodilators for symptom controls. Indian guidelines affirm that nebulized formoterol is useful as bronchodilator for regular maintenance therapy in COPD and as needed reliever therapy due to its rapid onset of action. I must say that I was really happy when I was able to read this sentence, because it's a long time that I'm affirming that probably in the treatment of COPD and the treatment of asthma, the best beta-2 agonist is formoterol, because of these important characteristics, properties, as you prefer. However, I must also highlight, as stressed in your guidelines, that formoterol in your country is only available in combination with budesonide and not as monotherapy, whereas we have formoterol as monotherapy in my country. In elderly patients with obstructive airway disease, it's recommended to make an appropriate choice between nebulizer and MTI, of course with spacer, but we must consider various device and patient-related factors in order to optimize treatment outcomes. The document also stressed the importance of domiciliary home maintenance nebulization therapy that is recommended to safely and effectively deliver a therapeutic dose of the required drug in a selected set of patients who are not able to use other modes of inhaled drug therapy and need it for regular or frequent use of prolonged period. It stressed the fact that handheld devices, MDI and DPI, of course, have their own shortcoming, especially in cases of infant and elderly, and nebulization therapy can be used to overcome these problems. Patients that require nebulization for 2 or more weeks must be categorized under DHM. And the selection of DHM nebulization must be done properly based on indication and not just arbitrarily. This is a sentence that left me thinking about, because usually we must always done our choices for all we do with our patients, considering indication and not just about what we believe in arbitrary manner. Sorry for this deviation, but this is an important concept. And domiciliary nebulation criteria should be also include must also include the type of drug. Of course, the drug must be available only in liquid form. The long-term maintenance treatment. This means bronchodilators and corticosteroids, and also the use of an adjunct therapy for prophylactic or therapeutic use, antibiotics. This last point is extremely important because there is an increasing evidence that a large group of patients suffering from COPD also suffer from bronchiectasis. There is a COPD bronchiectasis syndrome, as there is an asthma bronchiectasis syndrome that we must always consider and explore for. And in this case, inhaled antibiotics are extremely important. In any case, in my opinion, regardless specific formulation issues to be overcome that can make one nebulizer to be preferred over another, the cost of the device for nebulized product is greater as initial outlay, but it can be amortized over months of year of treatment, making it similar to that of portable inhalers. This is something that we stressed 9 years ago and is still extremely real concept. And in effect, a recent American study have documented that automatic formulary substitution of nebulization solution for inhaler medication significantly decreased medication costs without increasing the average number of respiratory care practitioner visits per hospital stay. That means a real higher cost in the management of these patients. Also, when I think about nebulization, I remain of the opinion that the budesonide formoterol combination is the best approach. There is solid evidence that formoterol inhalation solution is similar to formoterol DPI in patients with COPD. And there is also evidence that nebulized budesonide may be an effective and safe alternative to systemic corticosteroid in the treatment of exacerbations of COPD. In any case, I think that the expert panel consensus produced in Thailand is extremely interesting, and I suggest you to read this paper. According to this expert panel consensus, in patients with severe acute exacerbation of COPD, with impending respiratory failure, high-dose nebulized budesonide, they suggest 4-8 milligrams daily, may be added to systemic corticosteroid until clinical improvement. Of course, no longer than 10 days. Otherwise, you must think about the side effect of steroids. In patients with mild acute exacerbation COPD, who have a slow response to systemic corticosteroid, the recommended dose of nebulized budesonide is 1-2 milligrams every 12 hours for 3 to 7 days. Whereas high-dose nebulized budesonide may be considered as an alternative to systemic corticosteroid in hospitalized patients with acute exacerbation of COPD under these circumstances. Patients at high risk for adverse effects of systematic corticosteroid, such as hyperglycemia, serious infection, including pneumonia or sepsis, but also in patients with an uncertain diagnosis of acute exacerbation of COPD, especially or acute exacerbation of COPD, especially when occult infection is possible diagnosis. And also patients with comorbidities such as bronchiectasis, osteoporosis, or poor controlled diabetes, cardiovascular diseases, and uncontrolled infection must be controlled. Patients' response to budesonide should be reviewed after 2 to 3 hours or earlier, depending on the clinical urgency, of course. But this expert panel consensus also gives suggestion on the use of nebulizer budesonide at home in patients suffering from stable COPD. They suggest that nebulization provides an alternative method for drug delivery in COPD patients who require treatment with inhaled corticosteroid. And this includes, but is not limited to, patients with frequent exacerbations and those unable to correctly use DPI or MDI. In this case, the dosage is lower, of course. The recommended nebulizer budesonide dose is in these patients is 0.51 milligram a day plus and on bronchodilator therapy. And this means budesonide formoterol, of course. In conclusion, I think that there are several clinical scenarios that we must consider in which we must prefer nebulizer therapy instead of other methods of delivering drugs by aerosol. And I completely agree with my dear friend Omar Usmani. You know very well that Omar is an Indian colleague that lives in the UK. Now he is British. He considers himself British, but he's always an Indian colleague, as I always joke with him. Well, he has stressed that there are 9 clinical scenarios that we must consider. Patients with cognitive impairment. He mentioned Alzheimer's dementia, intellectual disability, or altered consciousness that preclude effective use of adult inhalers. Patients with impaired manual dexterity due to arthritis, Parkinson, or stroke. And don't forget that many patients suffering from COPD are old people that suffer from these problems. Patients who have severe pain on muscle weakness due to neuromuscular diseases. Patients that are unable to use MDI DPI in a normal manner, although adequate instruction and training. Omar was thinking about patients who are generally debilitated after hospitalization or by chronic illness and are unable to coordinate their breathing with MDI or cannot generate adequate inspiration flow for effective aerosol delivery from a DPI. Patients with inadequate symptom relief with appropriate use of DPI, MDI. Patients who do not comply with the use of MDI or DPI or who prefer to use nebulizers. Patients who need respiratory medication that are not available in MDI or DPI formulation. Patients who need higher bronchodilator and corticosteroid doses for optimal control of the disease, or when multiple agents need to be co-administered. And finally, patients who cannot afford therapy with MDI or DPI. Well, I think that these suggestions are extremely important. I must confess that we always consider this aspect when we treat our patients and when we should prefer or we want to prefer nebulizer over other inhaler treatment. Thank you very much for your attention.
Thank you, sir, for the wonderful lecture. Can you stop sharing, sir? Thank you. Over to you, sir, Dr. Talva.
Thank you very much, Professor Cazzolo. I think it was one of the, indeed, a document in which you have tried to, I think, collate the data from whichever part of the world the nebulization is, I think, a very important practice to treat the obstructive airway diseases. I'm very delighted to see the data from Thailand. I think there is one from Chinese also. There's a lot of data which is there. So looking at that, we have a lot of new things which we have learned here. And I think in the Indian context, when we discuss all these things, then very important would be the couple of things which come into our mind all the time. And very are like perhaps we are spoiled by choices which are available to us in the nebulized therapeutic drugs armamentarium, because we have lots of drugs available. Maybe a couple of them are still in the process where we might be getting it in future. But this is definitely one of the things which we keep in our mind. And to begin with this panel discussion, I welcome you along with my friend Mahavir and Visweswaran. And they are I think, one of the leading pulmonologists, one of the most leading pulmonologists of India. And I think they will vouch for it, that nebulization is a very important treatment, what we see in our part of the world. So I think the first question, which is the most important, is that, Mahavir, where do you give preference to nebulizers in managing your patients of COPD? So what are those kind of situations? I think the last slide from Professor Cazzola was great, from Omar Osmani, which had given almost 9 or 10 indications. But the last one, I was like very, very amazed to see that if they cannot afford PMDI and DPIs, how can they afford nebulizers? Because obviously the cost of PMDI and DPI is much cheaper in India as compared to the rest of the world. So I think that's the only point which will be not valid to, as far as India is concerned. But the first other, like 7 to 8, what's your comment on that?
Yeah, thank you so much for the question, and thank you, Professor Kozula. It was an enlightening talk, and we are from an era where initially we used to give talks saying that we should not be using nebulizers in asthma and COPD practice, because that was the time when only SABA and SAMA were available in the uh, nebulized form. And nowadays, because we have this LABA, LAMA, and very soon even the ultra LABAs will be available in the nebulized formulation. So I totally agree with whatever we have discussed up till now. And most of the times in my patients, I do use nebulized practice, of course, in acute exacerbations. That is something which goes without saying. And I have started using even LABA and LAMA as combination therapy, even in patients in acute exacerbation coming to casualty, not only giving preference to SABA SAMA, because even I think the LAMA also act as quickly as compared to even the SAMA. So I started using this LABA LAMA combination along with inhaled corticosteroids in many of the patients, even in intensive care unit as well as in the emergencies. And many of the times I have stopped using SABA SAMA in these patients, especially when I feel that I don't have a very severe kind of exacerbation, because only limitation is to keep on adding the dose, or maybe you should not be giving too much of this LABA LAMA in the inhaled form. So that is only one prerequisite. Otherwise, then even in patients, those who are just after exacerbation, and if they're not able to use PMDI or DPI, and once they're shifted home, or once they're shifted from the intensive care unit back to the wards. So I think those are the conditions. And patient, those who are of course not able to use their DPIs or PMDIs, those who are not satisfactory results even after using these inhalers in the correct formulation or in the correct way. And of course, sometimes if we have patients with, say, maybe Parkinson's, stroke, or then patients with Alzheimer's, arthritis, those who don't have that much of hand-mouth coordination. So there again, I keep on using these nebulization therapies. So I think largely, if you see in my COPD patients, I have almost 50% of patients, those who can be offered treatment with long-term this nebulization formulation.
Well, to be honest, you know very well that I'm one of those who believe that combination of two bronchodilators, apart the method to deliver them, should be considered the first step in the treatment of COPD, because a dual bronchodilation can optimize bronchodilation. Don't forget, you know very well, you are an eminent specialist, that the highways are under the control of vagal system, and there are a lot of beta adrenoreceptors that can be stimulated by circulating adrenaline and noradrenaline. And furthermore, there is a crosstalk between vagal system and sympathetic systems. So the idea of having a LABA-LAMA combination as first step to treat our patients is extremely important. However, to the best of my knowledge, there is no attempt to have such a type of a combination to be administered by nebulization, likely because drug companies have no interest in producing this. Don't forget that many companies have their own devices and they prefer to sell the drug according the use of their devices because the cost is higher and is better for them, linking to the property of the device. That's extremely important issue that you cannot forget. There are many other drugs that can be used by nebulization. Please don't forget, for example, that the newest drug that seems to coming on the market maybe next year, that is encifedrine, that is a PD3, PD4 inhibitor. They presented this drug at the last ATS, but we were working on this drug from at least 10 years, even more, I think, that 10 years. Still is delivered by nebulization. So it's extremely important, and it's likely that he will come into the market as a nebulization formulation. And when they asked me some suggestions about the development of this drug, I always suggest them to put this drug together with a LAMA, maybe glycopyrronium or glycopyrrolate, as you prefer, because this is outside the brand, so it's outside, can be used in a free manner, can be developed in free manner now. It's out of patent, to be honest. And because there is a pharmacological reason that explains this. This means that even glycopyrrolate must have been administered by nebulization. And in some countries, to the best of my knowledge, there are the possibility of finding glycopyrrolate by nebulization. I don't know in India. In Italy, no. Although we are pushing on health authorities, the present Minister of Health was my former rector at the University of Tor Vergata. He's a good friend. And I explained him the importance of having such a type of approval because it's extremely useful for the everyday activity. I don't know. The problem is that what is true in Italy, also considering the cost of the national system, is completely different from your country. So I cannot give you suggestion on how to treat patients. This is strictly linked to what you have and what you can use and what is not expensive for many patients is that cannot spend a lot of money for the treatment. The important is that these patients can be, in any case, be treated.
You're muted.
Sorry. Thank you very much. And I think it would be great when we get newer drugs added into the armamentarium, and especially with PD3, PD4 inhibitor coming in inhaled form. And perhaps if it is added with a LAMA, so at least we will have a combination where ICS is not must and can be given by a nebulized form. But of course, we'll wait for that time. In the meantime, Vishweshwaran, I think there are a couple of things which are, come up in the discussion point. Cost is an important issue when it comes to nebulization therapy. And particularly the nebulizer is not so expensive, but the drugs are more expensive and it's got more recurring cost in comparison to a cost of a nebulizer. And particularly, I think we are no way different from the rest of the world, particularly what Professor Cogello has said about Italy, that almost, I do not know how many % of homes in India, but they do have nebulizers, whichever are actually the jet nebulizers. So that's the one which is the common denominator in the houses, which is a jet nebulizer. So how do you go about the the placement of therapies vis-a-vis cost? So how do you weigh those things? I think that's the one question which comes to the mind.
Yeah.
So as As you said already, the cost of the nebulization is going to be a concern always. So in our center, we try to use the nebulizers only for the people who are not able to use the MDIs or the DPIs, as well as for people, especially post exacerbation, when we feel that they don't generate enough inspiratory flow to cause an optimal deposition of these drugs through a DPI or an MDI formulation. So apart from that, another area where we find a lot of utility of these nebulizers is in the emergency setting, as well as in the ICU setup, where we still tend to incline towards more of utilization of the drugs using a nebulizer rather than a MDI and a spacer formulation, even though the guideline says that MDI spacer is as good in comparison to your nebulizers. So cost will always remain an issue when we don't have a universal coverage, and so we try to restrict the use of the nebulizers only in a limited setting. For most other patients, we try to give more of a breath actuated inhalers, or we try to use a DPI or a MDI with spacer. So that's how we are triaging the cost aspect in our center, sir.
So I think you brought this point that those who are not doing well with this, or those who cannot afford, will obviously be on a cheaper devices, and there are equally good devices which are available in India which can be used now. But yes, the role of this nebulized remains in largely a lot of number of patients who are very severe or who can't use it. And I think you gave almost similar profiles as Mahavir has also said, which is there in the Osmani statement. But Mahavir, I will come to you with this question. The Gold also addressed it, and we keep getting anecdotal, references at multiple places that there are some people who are hungry for more bronchodilation. And these are the people of COPD who do not respond to the routine dosages, and they need a little higher dosages or a much higher dosages, which can only be delivered by nebulized bronchodilators or combinations which are available in our country. So what's your take on it, that in your practice, do you find that this group of people are there who are only satisfied with nebulizers because it gives them extra kick or extra dosages delivered, which causes superior bronchodilation in comparison to their usual devices?
Yeah, of course. I mean, I agree with this because there are a lot of patients, especially after exacerbation, and then there are patients, those who have comorbidities. So they normally need higher dose of inhaled corticosteroids, and there are category of patients, whatever inhaler you give them, the kind of benefit or the kind of kick, what we say that they get it through nebulization, it is something which is very satisfying. And these category of patients, they are quite happy with that formulation only, that they want nebulized. So definitely that population is there. And regarding the cost also, I always feel that in these patients, they are managed with LABA ICS plus LAMA as a nebulized formulation. The kind of exacerbation what it can reduce, and plus the emergency hospital visits, if the casualty visits are also reduced, I think then the cost surpasses the the exacerbation plus the going to the emergency kind of setup. So that definitely is one benefit. And just to clarify, Professor Kazola, that I was saying LABA ICS and LAMA as separate. We don't have LAMA in this. But whenever I'm giving nebulization, it is LABA ICS in one reticule and the LAMA in the another one. So that is how we are managing these acute exacerbations.
So is there any point, Mahavir, in giving them in separate? Can't we combine all three together? Is there issues in their, compatibilities when they are put together? Is there something like that?
I feel yes. I mean, we can definitely, because glycopyrronium has once a day as well as twice a day. The studies are like with all kind of formulations of glycopyrronium. But I'm always happy to use it twice a day as compared to once a day. Even formoterol twice a day and budesonide also twice a day. So I feel that we can combine all of them together. I really don't know about the in the nebulized formulation, how will be the pharmacodynamic and kinetic, whether they will change. But if studies are there, I think combining all of them together can be a great advantage in all these patients, just like we have single inhaler triple therapy. So similarly, if we have all these three available in one rescue, I think it can definitely change scenario in many of the patients.
Yeah,
Only
I
problem is I think is de-escalation becomes a problem in some of these patients.
right. And I know that there are efforts being made to combine all three together so that it comes in one vial morning and one vial evening, and all the triple therapy goes into it. Coming to you, Visweshwaran, I have one question to you. That, you know, when this nebulized LABA, ICS, and LAMAs are given in the emergency situations, like you said, you use short acting and add on to long acting, or you use only short acting and keep using a lot of short acting till you find the patient is better, and then you shift them, and then SOS short actings go on. So how do you manage in the emergencies these kind of nebulizations?
So generally, we are moving away from more of this short-acting beta agonist. We are trying to prefer more of formoterol budesonide combinations even in emergency setting. But only one, there are few cases patients with extremely severe bronchospasm who, after despite giving one dose of formoterol budesonide, they don't tend to respond. Only in those cases, the second dose we don't again give a formoterol budesonide. What we do is we give them more of a SABA combination to just tide over that interim period of bronchospasm. But for most other patients, we give formoterol budesonide as the starting dose of nebulization, even in an emergency setting, because formoterol, as we know, has got a has got a long acting as well as a fast acting property. And ICS we give for covering the inflammatory aspect of the bronchial asthma when these patients present in an acute exacerbations. And another area where we always tend to prefer a formoterol budesonide combination in a nebulization form is patients with underlying cardiac comorbidities, where we don't want to expose them to repeated nebulizations with short-acting beta agonists, which tend to have a poor cardiac profile in comparison to this long-acting ICS combination. So most of our nebulization practices as on date are more of long-acting LABAs with long and fast-acting LABAs with an ICS combination. And if they don't respond, then we add a SABA as the subsequent dose. And for COPD patients, sometimes, as we discussed, we give SABA, SAMA at times, like a combination at times in the emergency settings.
So, Professor Kajola, what is the practice like in Italy, that when these patients come in the emergencies, do they have access, or do you feel that these patients are using formoterol and budesonide and some kind of this nebulized combinations which are long acting, maybe 12 hours or so, rather than all short actings which are generally used most of the countries? So what's the practice in your part of the world?
Well, I can tell you what we do in Tor Vergata. That is to avoid, when possible, the use of salbutamol, and to be focused on formoterol, because, as correctly our colleague told us now, we believe that the use of fast-acting formoterol is fast-acting as salbutamol, and is much better taking advantage of a long-lasting activity of this drug that salbutamol has not. We use generally the combination of an ICS with formoterol, and we increase the dosage of formoterol when the heart allow it. Don't forget that in any case, even if formoterol is selective beta-2 agonist, such as salbutamol, there is always the risk of activating the beta-2 receptors that are present in the heart, and because of not real selectivity that all beta agonists have, we can also activate beta-1 receptors in the heart. So if it's possible, we also increase the dosage of formoterol. Don't forget that there are documentation that formoterol has been used by DPI-MDI up to 96 microgram per doses. That's instead of 12 microgram, that is the usual dose. And we increase the dosage of inhaled corticosteroid or we add the oral or systemic better corticosteroid, to be honest. That's very important. An approach that we are also using in COPD is when it is possible, the simultaneous combination with beta blockers, because we believe that the use of contemporaneous use of beta blockers can protect the heart a lot, and also has a very good impact on the possibility of increasing the sensibility of beta-2 adrenal receptors. So of course, we use beta-1 beta blocker, cardiac selective beta blockers. And this is something that seems to be extremely useful. In any case, when it's possible, we prefer to use nebulization in emergency room and also for severe ventilated patients. Whereas when we discharge the patients from the hospital, we must move to usual MDI, PDI, because of our national system that facilitate the use of MDI and DPI instead of nebulizators. And this is a problem because several patients prefer to remain under treatment with nebulizers, I must confess. I have no exact figures of this, but I can guarantee that a lot of patients, a huge number of patients, prefer to remain under nebulization after having been treated in hospital with a nebulizer.
So I think you brought a point which I would like a little more clarification, that you said that, if because of the use of bronchodilators in acute exacerbation COPDs, there may be too much of tachycardia. There is the heart is racing too much. So you said you would not shy away from using beta blockers, cardioselective, because these are COPD patients. So these beta blockers are used to control the heart rate or to control blood pressure, or have concomitant tension?
To be honest, probably you have seen our papers that documented the usefulness that we have produced even with Nick Canania in Houston or Clive Page in London, in which we documented that there is an increase of response of beta-2 stimulation when we use also beta blockers in COPD, and also there is a big advantage in considering the heart problems. That's a problem that why we like a lot to, when we can use beta blockers with beta-2 agonists. That's extremely important. Please consider there are 3 or 4 papers of our group, and another will be published in Drugs in few days, I think, because I have edited the proofs in which we explain why this effect is so important. Of course, I think that this is possible in hospital, probably because we have the patients under the control. At home, this is less useful, or the physician may be less, may have less practice with such type of approach. So we cannot suggest it at home, but in hospital, it's extremely useful.
So I think I'll ask Vishweshwaran to have a look at these articles, and if you get hold of them, please send it to me also. I'll be very much interested. And I think it
British Pharmacology and other papers on that you
will definitely go through it, because racing hearts in this acute exacerbation management is a difficult situation, and most of the time our country uses ivabradine to control that, or diltiazem to control it, not beta blockers. But we know that cardioselective beta blockers are actually good for the patients of COPD who have got any cardiac issues. Either they are imminent, or they are already there, or they can come. All those situations are very good for that. I think you have very nicely elaborated it, and I want to go to the next panelist. But before that, I want one more answer from your side. That when we are talking about this COPD group, which is inadequately controlled with the our PMDIs and DPIs, and even when everything is correct, they are using it correct, just because they have severe disease, they have severe dyspnea, it does not respond to it. Is that group for nebulized just because their symptom burden is so much, although they can use their devices very well, but symptoms are not controlled with whatever max we are using. So is this kind of patients, how do you see them in your practice and manage them?
Well, of course, we use the increase of dosage of drugs that we are using. We add other drugs. This is the group of patients that can also be treated with a triple therapy or with the addition of roflumilast, waiting for encipheline, of course, or for tamifluase, that is an inhaled PD4 inhibitor that should be entering into the market very soon. And also, we believe that in some small groups of patients, the addition of a macrolide could be extremely important. The problem is that in this case, you must be aware which kind of devices you are using. For example, if you must reach the small highways, well, you could have problems with the nebulizers. It's better to use the new devices, soft mist, or the devices produced by other companies that are extremely useful for reaching small airways. And but even when you use such type of devices, you must always or often add a third or four drugs to the treatment, ready to de-escalate the therapy when the patient improves to reduce the risk of side effect induced by this aggressive therapy.
Thank you. Mahavir, what about the title, from the hospital to home? So you discharge your patients on nebulized or change them into inhalers at the time of discharge. And what are those criterias which you take that these patients are going to go home on nebulizations and these are the ones who are going to be changed to the devices before you discharge them? How do you take that call?
Yeah, I think it's a tricky situation sometimes, but most of the times I will like to convert my patients from nebulized to a PMDI along with the spacer, especially if patient's general condition is okay at the time of discharge and he doesn't have a lot of comorbidities. He's not like overloaded with the prescription. So I think in those category of patients, depending upon the education level plus the family staff and the supporting staff what the patient has, so I try to shift these patients from nebulized to the PMGI along with the spacer in most of the situations. But sometimes the patient has other comorbidities if they have some neurological element, plus if they have stroke or if they have hand-mouth coordination problems and geriatric age groups. So I think these category of patients are the ones where they will be continued even at home also with nebulized therapy. So these are definitely some of the, some patients are the one those who will demand nebulization and they feel that, this is something which I have at home and I will like to continue with this and don't want to shift immediately to the inhalers. So I think for those category of patients, I keep them on nebulization. I don't force them to convert to the inhalers. And once they are walking or if they are absolutely out of exacerbation and on the first follow, then that's the time when I convert them from nebulization back to the inhalers. So that is what I do for most of my patients.
So coming to you,
Professor
there is-
Talbot, add another important point that I forgot to mention, that probably when we have a very severe COPD patients, we must start also to consider biological treatments, considering now the new one that can act also on neutrophil inflammation. And we strongly believe that probably these drugs, because of pharmacokinetic problems that we have with biologic drugs, could be tested by inhalation. And by inhalation means by using nebulizers. That's an extremely important point that should be considered and developed very soon.
So Vishwesharan, coming to you about, we were talking about discharging them either on nebulization or the inhalers and try to shift them to inhalers, and some of them won't be able to, and you know that those critically. I'm asking you a specific question because, you know, a lot of time due to the financial crisis, we need to send the patients before they are settled. They are still undergoing an exacerbation. They have not received full treatment, but they are little better than what they were at the time of admission. Now they have to go home. So generally in our practice, we try to send them all on nebulizations because we don't want to just come back very next day. So how do you see these patients? I'm sure you must be also seeing these kind of patients. So is it the same thing which you do in your practice also?
Yes,
Yeah,
of
we
course.
all, yeah.
Right, go.
So, yeah, so until and unless we feel like the patient is out of an exacerbation, we generally don't force them to take inhalers or DPIs. As we said before, the inspiratory flow may not be optimal enough to generate a proper drug deposition. So we make sure that we send these patients on only nebulization. And another thing that we found pretty useful is we don't give them the face mask. We ask them to use the mouthpiece so that the wastage of the drug through the nebulizer comes down significantly when we start using through the mouthpiece, especially in few cases where we give inhaled antibiotics. So we ask them not to use the face mask, rather than use the mouthpiece so that they don't waste this drug. And so you are very right, sir. And we see a lot of patients. I think both of us work almost in a similar setup. So we see a lot of patients who go home pretty before the stabilization of the underlying condition for which they came for.
Obviously, they need to, keep some money for the next exacerbation because they have to come back again to the hospital. Anyways, I think that's an excellent point which you have raised, that we are very a lot of times other forced to practice this kind of things, which perhaps may not be so common in the West. But yes, there are a lot of other things which need to be discussed, and we have very little time. So quickly, I go through a couple of more things related to nebulization practice. That once we send them at nebulizer at home, what is the time that you try to get them back to their inhalers, and how do you manage it? So that's the question. Mahavir, I'm coming to you for this question. How do you manage? We have sent them on nebulized. Now they come for follow-up at 2 weeks, or maybe, generally 2 weeks, maybe then later on at 2 months or 3 months. So how long, how do you manage this? Because I find very difficult, because they are so happy with those nebulizers that the moment you bring the discussion that we are trying to shift you back to the nebulizer, they immediately say, no, 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 don't do anything. And of course, they are very scared because they have just been out of the hospital. So how do you manage these kind of situations?
I think the basic problem with nebulizers is the way they are used. Okay, because we know that they can be a very big source of carrying infection also, because most of the times the nebulizers what they are using, and even the nebulizer kits, so they are not sterilized, or they are not disinfected properly, and that can be the reason. So I always tell them that the dose of the medicines in the inhaled corticosteroids also is quite high. That is one thing. Second is the cost issue, and the third is the way it should be disinfected after every use, or at least keep on changing them once in a week or so, at least the tubing. So I ask them to change it maybe once in the 5 or 7 days. So considering the cost and plus the higher dosage of the inhaled corticosteroids, and plus the LABA, LAMA, whatever they are in the nebulized form, they are much higher as compared to. So when I tell them that I have to cut down the dosages, and that is the reason that we have to cut down from the nebulizers to the inhaler, I think that's the time when most of the patients do agree. And as Vishwanath said, that if the patient is absolutely stable and he's not in the mild moderate exacerbation also, so that's the time when I normally change them from nebulizers to the inhaler form. And most of these patients will be on single inhaler triple therapy in twice a day formulation with inhaler along with the spacer. So I think that is how I go with for most of the patients.
Yeah. So I think there is no standard practice. I'll just like to share that, I find patients when very jittery. We are lucky because we have triple therapies available in this inhalers also. So I'll tell them, okay, one time you take nebulizer, the other time you take inhaler. And if you feel you are stable and I have not actually rocked the boat, so you might as well go to the other one slowly, and they do behave that way. Otherwise, it is really sometimes very difficult with them. You're correct. So I think infection point is very importantly you brought in. So how is the cleaning and other things and infections related to it? I think in my practice, I have ever thought, like, if I think that how many times I think of it that it is the infection has come from the nebulizer, it's like very, very uncommon, very, very uncommon, I would think about it. So I feel, it is something which is, I do not know. It depends upon how you have, how they are cleaning it, and all those things are very important. And I do accept that it also depends upon the kind of patients, their caregivers, and how much educated they are. It will depend upon all those things. But infections related to nebulizers, repeated kind of infections, how common are they seen generally? Actually, Vishweshwaran, what is your again? We are from the similar strata. I think Mahavir is also from the same. All three are incidentally in the same group today.
So, so actually there is a bias in this, sir, because the patients in whom we generally send them on long-term home nebulizers are per se severe COPDs who are prone to get repeated exacerbations, or patients who have underlying bronchiectasis, who are again a candidate for getting recurrent infective exacerbations. So I feel like most of these patients who come back with infective exacerbations may not be primarily because of device related only. Maybe it is because they have such a sort of underlying lung condition which makes them prone to develop these sort of infections. So I think in our setting, maybe that disease specific bias might also be there whenever we are thinking about infection related to the nebulization, because we end up giving this nebulization only for these severe forms of lung condition patients. But however, we make sure at least our residents say to them about maintaining the disinfection of the nebulizers. But one practice, unfortunately, which I have observed, is like sharing of nebulizers is still common amongst people where the family have 2 or 3 patients who suffer from advanced respiratory disorders, which is to be strongly discouraged. And I think somebody, at least supportive staff, should specify them, because what they do is they buy the medicines, but they use the same device, thinking that except for the mask, they don't change the tubing, because we just say that change the mask. We forget sometimes the caregiver fails to understand that the tubing can also be a source of infection. So I think these are like certain practical difficulties which we face. So when we say to them, we need to make sure that they change the mask, they change the tubing as well. If at all they want to use the device, ideally, and separate devices, what is ideal, but maybe that may not be possible in every scenario where there is a lot of patients in the same home.
I think you brought this point very well, that this happens, and this doesn't happen only in India. It happens all across the world. That if there is a nebulizer at home, the child gets through that as well as the grandfather gets through it. So I think that's a common practice, but teaching them is very important. But we feel a lot of, I think, the fear of infections versus the benefit to the patient is something which is like risk versus benefit. You always need to consider in individual patient, and that's a very important thing to be kept. So I'll come to one more question now, actually, and it is open to all three of you. How long we can continue nebulized therapy for these patients of COPD? Because number one, they are not going to be all right. Number two, that they are already reached that part of the disease, which is now going to go progressively down and become worse and worse over a period of time. And we know that all these therapies, I do not know how much is the data that, but we, at least in the last 40 years of my practice, I have seen people who were not expected to live even for 5 years are now living for 30 years. So if that kind of a longevity has come in people, so obviously this is going to be like a very, very long kind of a therapy. So how long? If somebody asks the question, how long? So I think Mahavir, you, and then I think Professor Kazola.
Well, I must tell you that usually patients tell me if they are in activity that they prefer to use MDI or DPI because they have no time for the inhalation or use of nebulization, of course. And usually I must, but I am focused on Italy, of course. That is the difference from your country. We usually, when discharge patients from hospital and he or she has been treated with the nebulizers, we suggest to maintain this nebulization for 2 to 3 weeks. After we revisit them, don't forget that there is a risk of a candida in the mount. That is a risk that many patients, mainly when they use corticosteroid, they can suffer from. If there is no real side effect, we ask the patients if he or she prefer to continue or he prefer to move to handheld devices. And I must say that if they are in activity, they prefer to be moved to handheld devices, to be honest. So usually we don't use no more than 2 or 3 weeks after discharging the patients from the hospital. Sometimes if we must treat children, I am not very expert in treatment of children, to be honest. Well, but pediatricians tell me that they use this system of delivery of drugs also for period longer than 3 or 4 weeks, even 2 or 3 months. But usually they have to stop also because parents are not happy to continue with this system that is time consuming and always there is a risk because of, although educated people, trained people, risk of infection is always present. You are not sure that they clean the system in the better manner.
So, Mahavir, your take on it, because I know there are a couple of patients of mine who are like for years now on it, and they're just
absolutely.
I'm lucky.
I agree that, I mean, sometimes we have a patient who's absolutely not compatible or not adherent to the inhaler. He's not able to use it. So that one category of patient is always there. Second is, as I said, that I am really worried about the high dose of inhaled corticosteroids in these patients. So that may be one of the reasons that I want to shift them back to the inhaler as early as possible. And although we feel that it is maybe the exacerbation part itself, the disease itself, which is causing the exacerbation, but sometimes if you see the patients, the way they handle the nebulization kit, it is like they will wrap it somewhere, they will keep it under the table or somewhere, and they might be catching up the infection from there. We don't have any data or any way to prove that whether it is happening actually from the nebulization kit or whether it's a part of the disease. But if they take care of all of these things, I think there are I mean, at least maybe 5-10% of patients, those who are always on nebulizers. There are we are just not able to ship them back to the inhalers. So, and
big number
especially if
for
we
us.
have LAMA combination available. Sorry.
Which is a big number for us, actually, 5 to
Yeah,
10%.
it's a big number. Yeah, there are patients, those who are always on nebulizers. And especially those who have comorbidities and the prescription is very heavy. A lot of other medications are going on simultaneously. So I think there are some patients, those who are on nebulizers for years.
So, Vishweshwaran, what about mucus clearing drugs which are available in nebulization in India, particularly for patients of COPD, those who have got mucus issues, mucus retention, not the bronchiectasis. I'm not talking about bronchiectasis patient where guidelines are more clear, but we have a lot of COPD patients who have got mucoid impaction. They find it very difficult to bring it out. Even the CT scan will show you that along with the bronchial wall thickening, there are mucus plugs which are there in the lungs. So what is the mucolytics which you use by nebulization, and in which conditions?
So generally, it's been. I just want your opinion also, sir. Like we have found, like whenever we have tried to use a mucolytic for COPD, somehow they land up having a bronchial reactivity, hyperreactivity, in comparison to patients with bronchiectasis. This has been our observation, but we still try to use them, especially when they are in NIV and in an ICU setting where their cough reflex is little poor. Then in those conditions, we still resort to using this nebulization with N-acetylcysteine formulation, and sometimes we even give hypertonic salines to make them bring out the sputum. And even we found out nebulization with a simple saline, especially in a patient on NIV where they become dehydrated, the mucus plugs become dehydrated. We found that was helpful. But one thing which we are very cautious is sometimes in certain cases, they cause some sort of a bronchial hyperreactivity. So we pre-medicate them with the bronchodilators, and then we tend to use these mucolytic agents. But in a domiciliary COPD patients, we aren't using soap rampantly as we use for a bronchiectasis patient. We tend to give more of these oral mucolytics in comparison to the nebulization, nebulized forms of mucolytics, because we are still afraid of some sort of a bronchial hyperreactivity. And if it happens home, it becomes little cumbersome for the patient. I would also love to hear from you on that aspect, sir.
I think we'll ask Professor Kajola whether N-acetylcysteine nebulized is available in your country, or do you have any experience of using it? Because I loved one of your paper which you showed in acute exacerbations, high-dose inhaled corticosteroids were able to control that. Although that's a little older paper, but that was also a good paper. So have you used the high-dose inhaled corticosteroids or N-acetyl? I think these are two questions which I've clubbed together because of the shortage of time.
We just published on the use of oral erdostaine with inhaled corticosteroid with Peter Calvary, Vishavishik, and so on. Erdostaine was administered by oral route. And I must tell you that in the past we used N-acetylcysteine by inhalation. Even in combination with chloramphenicol, there was a formulation and it was extremely popular in Italy. But now you cannot find it in the market, and we use just high dosage of oral NAC or high dose of erdostaine with inhaled corticosteroid and beta-2 agonist, to be honest. And we no more use inhaled saline, and yes, they still can be administered by inhalation, but not erdostaine, not NAC, not more, because of the risk of bronchoconstriction. That is something that we observed in the past. And this is the reason why we don't have it in the market, I think, now.
So, Mahavir, your take on this N-acetylcysteine and erdocysteine is just recently been relaunched. I won't say launched, I will call it relaunched after the Gold has recommended it. Gold keeps us changing our practices very frequently, I think. Every time, one time you tell them that this drug is useless, you should not use it. And after 2 years, you start telling your patients, no, this drug is good, you can use it. So I think I find it very difficult to change so frequently. Erdocysteine now, because it is in the guidelines, so obviously it is available now. After, I think, hiatus of 6 years, it has come back. So what's your take on this? N-acetylcysteine?
Yeah, N-acetylcysteine, I do use it, but I use it mostly in the inhalation form in the ICU patients or the patient, those who are tracheostomized and those who have good cough reflex. So they are the one, those who will be able to bring out the sputum. And it works mostly along with your hydration, steam therapy, and physiotherapy. So alone, it is not going to work. And most of the times, I use it in the ICU setup in the nebulized form. Once the patient is discharged, I try to use them in the oral and dispersible tablet form. So I think even as Vishwesan said, that some of the patients, they do get reflex bronchospasm, but I have not seen it actually. It may be in some asthmatic patients, but otherwise, I have not seen it. It is, I think, more of a hype than it's actually been. And many times we use it along with the nebulized, say, LABA or maybe some Sabasama along with it. So that reaction is not seen that frequently. But yes, it works in some subset of patients. We still have to have a very good this mucolytic. I don't know even erdostaine also, but this it has some beneficial effect along with the macrolide group of antibiotics to enhance its property. So having an upper age as compared to an acetylcysteine, but still we don't see that much of the mucolytic effect of any of these medications, nebulized form as well as the oral formulation. But yes, we use it routinely in our practice.
Great.
So, your comment on this?
Regarding the mucolytics, sir?
Yeah.
That's what, sir. Erdostaine, Yes, sir. We have not. I don't have so much of experience, but we did use it in a couple of patients. I think it is definitely non-inferior, maybe to N-acetylcysteine. Whether it is superior, I think I need to use it in more patients to see.
I think we can ask Professor Kazola that what is ardocystine, where is it placed in COPD patients? Which patients it is going to be beneficial?
With erdostatin, you mean?
Yeah. Which group of patients of COPD?
Well, for sure, it's the patients that is suffering from chronic bronchitis. There's no question that's the typical patient that can take advantage of using NAC or erdostatin. That's typical. But in our group, we documented a very interesting anti-inflammatory activity with all thiols drugs. That it means also carboxysteine, not only erdostatin or NAC. And you can take advantage of this, in our opinion, using it for a de-escalation therapy. That means to maintain the patients with the dual bronchodilation and avoid to use inhaled corticosteroid because of taking advantage of the anti-inflammatory activity of thiols drugs. And I must say that now this point of view that we published in Trends Pharmacological Science 5 or 6 years ago is been accepted even by colleagues working in gold. And you know that when gold speaks, is gold.
Very it's gold for I don't know how 230 countries, and India is also one of them. We blindly follow, and we keep following them. Every year we get educated more and more. And I think it's like a circle of life. It goes through, it comes back. And we are seeing that because there are not many things happening. But you have told us about some new things which are coming up. So we are coming to the close of this 1.5 hour program. It was a marathon program. Excellent deliberations by my colleague Mahavir Modi as well as Visweswaran, and of course a very thought-provoking and a different kind of lecture by Professor Kazola, which initially started with making a way for the inhaled corticosteroids in COPD, contrary to what's going on on the gold all the time, and then going to build up to the nebulized, which is the reality. It is the reality. If you look at the US, the market of nebulized drugs is much more in COPD than anything else, actually. So everybody has the I think experience of using them and realizing them. I think it is a necessary evil. I think you need to use it. But of course, the infections and other things need to be kept in mind. You need to keep reminding your patient, and particularly those patients who can be shifted back. You continuously engage yourself with your patients in a way that you try to get them back onto their primary therapies which are there. But yes, some of them would be very, very difficult to do so. And I don't think so that any other country besides India would have so, or maybe others in the Southeast Asia, where so many patients are on nebulized therapy for a pretty long time, pretty long time. And that is perhaps something which is like eye-opener to maybe the rest of the world too. And we had a lot of good discussions today about nebulized therapeutic armamentarium in COPD patients. And cautions were few, and that is primarily, I think, infection related or maybe toxicity related if we are using it too much of dosages, because obviously the dose is delivered a little more as compared to what we get through the PMDIs. But I think these are there, which are going to be there, which are going to be there more and more. And happy to learn that there is a new drug which is going to come up, and that is PD4, PD5 inhibitor, and that is also going to be in nebulized form. And we have a glycopyrronium available. So even if they don't come with two together, we will be able to give at least two drugs which do not contain inhaled corticosteroids, and will be able to manage our patients where ICS is to be avoided. So I think great news, and I'm sure that much more is going to come. Today's webinar has been extremely educative to me, myself particularly, and I'm sure to a lot many people who are there on this platform and will continue to watch this because this is going to be on CiplaMed. I think for people who have not attended today can be there for later on. Thank you very much for Professor Kazola for giving us time from your holidays. This is your holiday time. We are extremely sorry to trouble you for that. And Mahavir and Vishweshwaran, thank you very much for the wonderful inputs which you have given me and enlightened me a lot more. Thank you, and back to Ashwin.
I think from Cipla, I would like to thank Dr. Kazola first for his fantastic lecture on the topic, followed by Dr. Talwar for excellent moderation as always, and Dr. Modi and for Dr. Visweswaran for their insight. That's it from our side. Thank you.
Thank you, thank you, everyone.
So much. Thank you, sir. Thank you, Professor Kazola. Bye, Vishweswaran. Thank you, Dr. Ashwin.
Thank
Okay,
you.
Professor.
Best
Thank you,
regard-
Talwar, sir.
Best regard from Capri. I am now in Capri. That's my house. So see you in the future. I hope so.
See you,
Thank you.
sir. See you.
See you. Bye-bye.
Thank you, Ashwin. See you.